Welcome to everybody for our January session of external speakers who we've invited along to talk about their links with histopathology. It's a great pleasure to introduce Laura Tim to you, who works for AstraZeneca as Diagnostic Manager. I first met Laura when I was working in genomics and got to know her quite well doing some of the cancer diagnostics there. And I think once we got talking, we realised that histopathology is quite an important part of everything that AstraZeneca do, and that's quality tissue and a quality diagnosis is what makes AstraZeneca's work actually happen, and none of it can happen without you all being involved in that preparation of tissue and diagnosis. So Laura's going to talk in general terms about how AstraZeneca use and interact with histopathology, and I believe, Laura, as long as the technology works, we've got some patient videos at the end as to how it all works together as well. So I'm going to hand you over to Laura, and thank you very much, Laura, for agreeing to come along. You may have met Laura, some of you, before Christmas, because she did visit the lab and was amazed by your skills.
Thanks for the introduction, Colin. Right, I will share my screen with you all now. So as Colin mentioned, I work as a oncology diagnostics manager for AstraZeneca. So our role is to increase awareness and access for diagnostics associated with therapies and improve quality in these diagnostics as well. So I'm going to just do a brief sort of recap around diagnosis of cancer specimens, and then we'll go on to talk more around the AstraZeneca role and some of the things we do in diagnostics and how important histopathology is. So bear with me while I sort of go through the first half, because the second half will be far more interesting. So obviously pathology plays two major roles in characterizing cancers. So these are histological diagnosis and molecular diagnosis. So histological diagnosis, obviously, as many of you are aware, as histopathologists, looking at the structural tissue components and arrangements to see if there's a presence there of disease. And allowing the histological diagnosis means that we can look at the actual disease progression sometimes by monitoring that longitudinally. Molecular diagnosis is looking at specific biomarkers. So these can represent abnormalities in the genetic or epigenetic pathways, but they're not just specific to the genetic pathways. There can be overexpression of tumor proteins as well. And these can drive activities such as proliferation and differentiation of the cancer cells. Because of the heterogeneity of these samples, particularly with cancers, having both a molecular and a histological diagnosis can be really effective for guiding therapy. And what we see as well is in that some cancers, there is a very small percentage of patients that actually have a molecular biomarker present. So it's still really important to know that histological diagnosis as well. And this is just a schematic of the kind of pathways of diagnosis. So obviously the histology piece comes first, and then you follow up with molecular pathology, and that allows the clinician to make those patient management decisions and treat the patient appropriately. So there's multiple ways that you guys end up with tissue in your lab. And often we will speak with healthcare professionals involved in the collection and the tissue acquisition process. So obviously there's fine needle aspirations, there's core needle biopsies, surgical biopsies, endoscopic biopsies, you've got scrapes, brushes, washings, urine, sputum. There's also circulating tumor DNA in the blood, but I haven't included that because this is more for histopathology. And all of these samples can be obtained and used to diagnose cancer. So once the sample is obtained, it's put straight into usually neutral buffered formalin, and fixed, and then it goes through the lab. And I had the pleasure of watching this process just before Christmas, being embedded in paraffin, ready for histopathology to look at the samples once they've been stained with H&E. So as a diagnostics team, we will work with clinicians at any point of this sample pathway. So we could work with radiologists, for example, in ovarian cancer, where molecular testing has not been standard practice. So normally one core biopsy is taken, maybe an 18 gauge core, which is sufficient for histological diagnosis, but there's not enough then to go on for molecular diagnosis. So we can work with the radiologist to talk about different techniques that will allow more tissue to be acquired without increasing morbidity of the patient. We often work with organisations to ensure guidelines are published around fixation and the appropriate fixation of small biopsies, for example. And then once that sample goes to the histopathologist, obviously it's really crucial, if that sample is going on for molecular analysis, that there is a good, robust tumour assessment completed, because without that assessment, the sample could go on for sequencing and effectively not yield a result. So when it reaches the molecular lab, the DNA and RNA is extracted, PCR amplification of the target genes completed. It tends to be nowadays sequenced, but there are different methods which we'll go into. And you do analysis of those results and interpretation, and then the report is obviously submitted and comes back to you guys as the histopathologists to feed back to the oncologists. So personalised medicine is the tailoring of all aspects of patient care to the individual patient. And what's really important with molecular testing is it allows patients to be stratified into subtypes based on their molecular biomarkers. And this gives the clinician the opportunity to treat that patient for their appropriate molecular profile. So, for example, if a patient has a specific biomarker, they can receive a personalised targeted therapy rather than kind of a bog standard chemotherapy treatment, which is given to larger cohorts. So one of the driving forces of personalised medicine is molecular pathology. There are many ways that we can use these samples to facilitate disease detection, to aid classification and diagnosis, predict disease outcomes as well, and also guide therapy. So it's now understood that most cancers are the result of an abnormal gene expression causing I can never say this word, proliferation. And the results of these genetic mutations in the oncogenic drivers will drive the growth of the cancer. For many years, researchers and us at AstraZeneca have explored biomarkers for predicting the disease outcomes, looking at detecting diseases as well, potentially where there are no clinical symptoms available. So molecular testing gives us the ability to drive to identify those driver mutations. So a really good example of this is for BRCA mutations in women with breast or ovarian cancer. So for example, if a relative has been diagnosed with breast cancer and close relatives are then eligible to go forward for BRCA testing, if the patient initially has a BRCA mutation, and that then gives the patients the option to prevent disease by potentially a hysterectomy or a mastectomy, for example. They can also be used to predict the disease outcomes. So, for example, a KRAS mutation is a prognostic biomarker. So patients with a KRAS mutation tend to have a reduced survival compared with patients of the wild type KRAS. And this is where I guess AstraZeneca has a real interest, and it's around guiding therapies. So the biomarker sometimes it's like a bit of a chicken and an egg situation. So for example, when AstraZeneca was initially trialing one of our EGFR TKI inhibitors, gefitinib, the trials were set up for all comers, and we saw initially that patients weren't responding very well to the therapy, and it was almost canned until there was a subgroup analysis, and it was found that patients who had a genetic mutation in their EGFR receptor actually responded really well. So then the clinical trials were designed to look at this subset of patients. And now, I mean, we all know EGFR TKI inhibitors are absolutely fantastic for patients with non-small cell lung cancer, and the outcomes are superior to that of chemotherapy. So sometimes trials are set up looking at specific biomarkers and aiming to look for molecules that could target that biomarker. And sometimes the biomarkers are an incidental finding. So, for example, with immunotherapies at the moment, we use PD-L1 expression as a marker, as a biomarker to demonstrate that a patient would get benefit from the immunotherapy. But we know that that is not the best biomarker, and there's still a lot of work going on to find the most efficient biomarker for that subset of patients, but we're not quite there yet. If you look at breast cancer, for example, by looking at the estrogen receptor positive cancers, we know that they will respond better to tamoxifen, and the therapies are developed to treat those patients. And again, you've got several therapies in the HER2 space as well. So again, this is just a schematic to kind of demonstrate the molecular diagnostics. So you could treat a patient group. So you've got lots of patients in here who are going to respond very differently to a therapy. But if you go back several years, I'm talking sort of 10 years plus, particularly in lung cancer, patients were just given chemotherapy. And the histological diagnosis wasn't even a consideration at that point. All patients with non-small cell lung cancer got the same chemotherapy. So some patients would respond and not necessarily have toxic side effects. Some patients wouldn't respond, would have side effects, or maybe wouldn't have side effects, but they all got the same thing. Whereas now with the molecular diagnostics, we can actually predict which patients are going to get benefit. So it also limits the number of patients that we're exposing to therapy where they wouldn't get a benefit and potentially would experience toxic side effects. So there are many ways of looking for these biomarkers. A huge amount of it is done through PCR and DNA sequencing. We're moving in the UK due to the Genomic Medicine Service centralisation to next generation sequencing. But there are still several methods out there that I use, like I mentioned, IHC, when we're looking at PD-L1, HER2, ER, etc., is still is very much used. And these diagnostics can be performed either in-house or they can be at a reference laboratory. So part of our role as a diagnostics team is actually to remove the barriers to molecular diagnostics, to ensure that every patient with a cancer diagnosis where there is an appropriate test to guide their therapy gets access to that test. So some of the most common barriers that we encounter in our role are time. So a lot of my experience has been in metastatic non-small cell lung cancer. And we know that when patients present, they don't have an awful amount of time. So it's really crucial that these patients can get access to the tests and get the results as soon as possible so that the clinician can start therapy quickly. And sometimes there are delays in ordering the test. There can be logistical issues. So we often will sit down and look at these pathways and try and remove as many barriers in terms of the pathway and the time that it takes for this testing. So reimbursement, I would say that was previously a barrier, still occasionally is, but I think we're really lucky here in the UK, in England specifically, that we have the new National Cancer Test Directory. So NHS England is funding many tests centrally, whereas previously funding of certain biomarker tests was quite obscure. Nobody really knew who paid for it. The oncologist would often think that the pathologist paid for it, and the pathologist would often say the oncologists paid for it. But now we've got a really clear structure for testing, and we know exactly which biomarkers are eligible for testing for particular cancer types. And it's all centrally funded through the NHS England. And the working test group also are horizon scanning all of the time, and we often submit applications to the test working group to add indications for certain biomarkers if we know that we're bringing a therapy to the market that's going to require a test. Another big thing that we encounter is tissue quality, and I can talk through how we can monitor this in some of our services, but ultimately, if the tissue quality is not good when it's sent for molecular testing, then often you can't get a result. So in a study that was evaluating the reasons for test failure, 65% and 29% of testing failures were due to insufficient tissue and insufficient DNA, respectively. So this is a big piece of our work. So on the positive side, some of the drivers to molecular diagnostics include the increased number of approved tests. And we are seeing that when a therapy is associated with a particular biomarker test, that test is also approved as well. And often if that therapy is going into the Cancer Drugs Fund, the company will often fund the testing as well as part of the agreement. So that helps to include that. Like I said, with the advent of the National Test Directory as well, that really helps to drive molecular testing. We see molecular testing included in many guidelines now. So locally, we've got the BGCS and the BAGPA guideline for tumour BRCA testing in ovarian cancer. We see ctDNA in the ESMO guidelines, for example. So they're now included in a lot of the guidelines. And IT is obviously always improving and helping us with this from terms of sequencing to the bioinformatics. So what do we do at AstraZeneca? Like I said, there's a 6 diagnostic managers and we cover the UK. I cover the east of England, and our role is driving the awareness of molecular testing, facilitating access and improving quality. Now, to be clear, I'm non-promotional, so I have nothing to do with the drugs. I don't sell the drugs. I don't sell any reagents or kits. I'm test agnostic, but I do sit in the commercial unit. So I do sit with the teams that are tasked with selling the drugs. But from a diagnostic perspective, we are non-promotional. We don't get involved in selling any of the drugs. But we work in the sites where AstraZeneca has a vested interest. So at the moment, those tumour sites tend to be lung cancer and ovarian cancer. And this year will be very much breast cancer as well. So some of the work that we've done, we've stepped in to provide testing services where the NHS hasn't previously had a service in place. So back in April 2017, I launched a UK-wide EGFR circulating tumour DNA testing service for metastatic non-small cell lung cancer. And this was for any patients with a diagnosis of metastatic non-small cell lung cancer, but it was particularly useful for patients who had progressed on their first line TKI therapy, and we were looking for the T790M mutation. And that is known to be the driver of progression for these patients in about 2/3 of the patients. But the problem in a second line non-small cell lung cancer patient is that they've responded really well to therapy, and it's very difficult to obtain tissue second time around because the tissue is quite necrotic, it's very small. So we developed the circulating tumour DNA service, where a simple blood draw can be used to then detect this mutation. So obviously much nicer for the patients as well, and significantly cheaper for the NHS. In 2018, we launched the tumour BRCA testing service for high-grade epithelial ovarian cancer. So previous to that, patients had only really received germline BRCA testing if they had a first-line relative. And there were certain criteria as to whether or not you could receive germline testing over here in Anglia. But tumour BRCA opened up testing to all patients with high-grade epithelial ovarian cancer, because we know that you could find potentially another third of patients if you look for somatic mutations in the tumour. And then April last year, we launched the HRD, homologous recombination deficiency testing for high-grade epithelial ovarian cancer. And again, this is a service that's not currently available through the NHS, so we are providing it, and we're also hoping to help the NHS labs to develop their HRD testing services so that they can take that back in-house. So some of the findings we get from the testing services we run are then presented back to the clinical community to help guide them. So often we will run our services for a specific amount of time, and then we will hand back over to the NHS when they're in a position to run those services themselves. So for example, with the ctDNA service, we published our findings at BTOG, and it was a lot of the ctDNA service was actually around logistics of handling the sample, how to take it, what tube to use, the pre-analytical handling, for example, and as well as the mutations and the detection rate. And then with the HRD testing service, at the moment it's still up and running. We've had a phenomenal influx of samples, way more than we were expecting, which is fantastic. And the clinical community are, I think, really appreciative of this service. The positivity rates are slightly below what we would expect, but it's always interesting when you run these services to see how UK data compares to some of the control data from the clinical trials. What we saw initially was that the failure rate of the samples was particularly high. So we had to investigate this further. Now, the assay that we use for this testing service is quite DNA hungry. And we've spoken to Myriad, who provide the service. So it's a send out model to America. And there was another assay that we could potentially move to, which used far less DNA. So we've done that, and we've seen the failure rate go from 26% down to 4%. So we're really pleased about that. But a lot of the work we were doing initially as a diagnostics team was discussing the failures with the histopathologists, ensuring that there was sufficient tissue sent across to Myriad, that a robust tumour assessment had been done to make sure there was more than 20% neoplastic cell content in the sample. And if it was below that, then could we potentially get more tissue? Was there any more available in another block? Was ascites an option, for example? So we do a lot of problem solving and making sure that no patient misses the opportunity to receive their molecular status, in this case their HRD status. So with HRD testing, if I take you back slightly, initially if patients would have germline testing for ovarian cancer, you could detect around 10 to 16% of patients with a BRCA mutation. When we moved to tumour BRCA testing, that increased to around 25% of women with a BRCA mutation. Now we have HRD, it's a wider biomarker, and the women respond just as well, but it encompasses a group of patients that are not BRCA positive, but are homologous recombination deficient. And up to 50% of women potentially can then benefit from a personalised therapy, rather than just having chemotherapy alone and not having potential outcomes that the PARP inhibitors bring. So again, when I'm talking about tumour assessment, we were very keen to help educate histopathologists or biomedical scientists that are doing the assessment of the tumour, and we've worked in collaboration with JNQA, who run tissue. So you may not have come across this, but it's an EQA that GenQA run for 9 different tumour types. We specifically worked with them on gynae, urology and lung, because obviously they are the tumour types we have an interest in at the moment. And it's around, it's not an EQA as such in terms of you're not benchmarked against anyone else. You are purely benchmarked against yourself, and there is an expert panel that also go through the samples and essentially give an estimation of cellularity and tumour content, and you can see how you sit compared to the expert panel. And it's purely for your own education, but it's a nice way of being able to say, okay, I'm competent at tumour assessment, particularly, like I said, if there's a speciality that normally isn't sending samples for molecular testing, like prostate, for example. BRCA testing is going to become something that's required moving forward, but at the moment there is no molecular testing required in prostate. So it's a nice way of kind of upskilling and learning about tumour assessment. So we partnered with GenQA to make this available in the devolved nations where it wasn't currently available. So at the moment in England, the GLHs have access to this free of charge, so anyone can enroll, but it wasn't available in the devolved nations. So AstraZeneca funded that through GenQA. So I'll stop talking. Any questions?
Laura, I've just got one question from Olivia about HRD and what it is. I was just about to answer it, but you can if you want.
Yeah. Okay. So generally when a patient is diagnosed with cancer and you're looking for a specific biomarker, say BRCA mutations, you're sequencing that specific gene. You're looking at BRCA1 and BRCA2 to look for a variant within that gene. With HRD, it's slightly different. You're not looking for the cause, but you're looking at the effect. So cancer cells have a huge amount of scarring going on from genomic instability. And if we look at homologous recombination deficiency, which in this particular assay looks at loss of heterozygosity, telomeric allelic instability, and large state scale transitions, that gives you a score essentially of genomic instability and tells you whether that cancer is homologous recombination deficient or not. And if it's homologous recombination deficient, then it's all to do with its ability to repair double strand breaks. And then that's where PARP inhibitors come in because of their mode of action. So I don't know if that makes sense, if I've clarified that.
Same as what I've just written in the chat room, so it must be right. Yeah. John Brown's just asked, did you think there's a role for artificial intelligence in tumour assessment?
Definitely. I think it's something that as a diagnostics team, particularly our diagnostics director, is really focusing on this year, because we hear from histopathologists all the time on the ground around capacity issues, particularly when it comes to tumour assessment and preparation of all these additional slides from molecular testing. So we feel artificial intelligence has a huge role to play in histopathology and can alleviate some of those tasks when it comes to like tumour assessment or, you know, PD-L1 scoring or things like that. Something that can be done through AI then means that the skilled professional can go on to do the other jobs that can't be done by AI and might alleviate some of those pressures you're seeing in histopathology.
Thank you, Laura, and thank you for the talk. Excellent, and gives us a flavour of what AstraZeneca are doing. I've had discussions with Laura since AstraZeneca are now on site, and I think we both agree that we need to work closer together and share educational resources. AstraZeneca have access to lots of things that they're quite happy to share with us. So anybody who's interested, just let me know and we can arrange for access to some of AstraZeneca's educational resources. And Laura's promised us at some point when COVID frees to let us into the building and have a look at their swanky new building. So
yeah, it's very nice auditorium there, which would be perfect for a little talk and then a tour. Any more questions? If not, I will finish with a video. Please. Okay.
And thank you very much.
No problem. So I'll finish with this video, which is ovarian cancer patients talking about their pathway as such, their experiences. And I think it's really important to always bring it back to the patient. This is why we do what we do, so that we can benefit patients. Sometimes you can get bogged down in numbers or slides, and ultimately, you know, there's somebody at the end of that. So I will just play this video, and thank you ever so much for listening.
It's now 10 years since I was told that I had incurable ovarian cancer, and I am living well. I am having no treatment at all, which is cancer related.
Since my cancer diagnosis, I've been so fortunate because a second grandchild was born, and my son finally at 40 got married, and now he has a 3-month-old little baby. I've gotten to see the first ballet recital for my granddaughter, and all these things become, as a grandparent, become important and so fulfilling that you can be a part of their life.
I was able to see my nephews grow up, because when I become sick, they are a little child. I become grandmother. It's happy because to have this little baby, it's a joy.
I had my golden wedding in June, and I really did not expect my husband and I to have that. So that was a big thing to me.
Being here, giving, sharing, trying to spread whatever you can, you know, the goodness. It's just, you know, life is good.
I'm happy I'm still alive. This means I survived 8 years and 3 chemotherapies. 3 years ago, I finished a marathon. When I'm running this marathon or the triathlon, yeah, I'm always thinking about, I have got it. I can run. I'm happy. I'm so happy that I'm able to do this. This is the best achievement I have.
It's a big reassessment of priorities, and having the cancer diagnosis and treatment as another part of the jigsaw made me think about, well, you know, I've been working all these hours and relationships with people are more important. You know, time spending doing something that I have a passion for is more important.
I'm very grateful to the surgeon and the doctors who found out what the problem was so quickly. I've achieved more than I imagined that I was going to, because I've been able to be involved in helping other people who are going through what I've been through.
You know, I'm grateful that there's this much interest in a rare tumor, but it's a rare tumor that affects women, and women are the matriarchs, and loss of moms and wives is just unacceptable globally. So I'm really grateful for the attention to this disease, and I think we're going to start to see some really science-driven, smart trials coming forward that will really benefit patients who need us.
So most of these women look back and they say, I feel so lucky. I've got all these plans for the future because I didn't think I would have the opportunity to have these years.
I have a sense of relief when I see patients in our clinic alive and well 5 years later. And I believe and I'm confident that this will continue.
Da ist ein Licht am Ende des Tunnels. There is always a light at the end of the tunnel.
Life is not about waiting for the storm to pass, but learning to dance in the rain.
Gil of the Hav. Here they call it the Golden Age, the Gil of the Hav. And I'm close. I'm close. I'm closer than I thought I would ever be. Let's put it that way.
I have a wonderful life, like Louis Armstrong said. It's a wonderful life.
Thank you. I think that's the end of the talk. Always nice to finish with a patient story. I should have mentioned that Laura lives in deepest rural Norfolk, so some of the issues are due to that. But thank you all very much for attending, and thank you, Laura, if you're still on the line. I can't see you anymore. And thank you for doing this for us. Greatly appreciated. And I'm sure this is just the start of our interaction with AstraZeneca in terms of education and training. And we were just chatting before this meeting about an idea for the next one with somebody else from AstraZeneca. So hopefully it will come off. Thank you all very much. Much appreciated. Thanks, Laura.
Thank you.
Bye now.